Thank you, everyone. So if we can all take a seat, please. We're going to be starting the afternoon session. So I'm afraid I'm a last-minute substitute today for Sally Moore, who, as Kerry said, couldn't make it join us today. But I'm delighted to be able to introduce the Michael Morley Lecture. So the Michael Morley Lecture takes place twice a year and very kindly supported by the Michael Morley Foundation. Just to mention, as Kerry said earlier today, that in the autumn day in November, we will actually be joined by representatives of the Morley family who will be joining for that lecture. And the theme of the next autumn day is going to be reflections on the last 25 years, because following through on the 25-year anniversary of the UK Myeloma Society. So we're reflecting, including some of our new members of the Myeloma Academy. We'll be giving some presentations, and we'll also be thinking about the future as well. So reflections on the past and also looking to the future in the management of myeloma. So do keep an eye out for that. I think it's on the 14th of November, and we'll be circulating some information about that over the coming weeks. So I'm delighted to welcome Niels van der Donk, who is a haematologist at Amsterdam University Medical Centre, where he's been a full professor since 2020. He's specialised in haematology, having trained at the University Medical Centre Utrecht, and then undertook a fellowship at the Jerome Lipper Myeloma Centre at the Dana-Farber Cancer Institute in Boston, where he spent his time before moving back to Amsterdam. He's obviously got a special interest in myeloma. He's the PI of many investigator-initiated studies in myeloma and translational research as well, looking at new targets with a particular focus on immune therapy. He's a co-author and author of a number of books and publications in peer-reviewed journals. He's also the secretary of the HOVON Myeloma Working Party and the scientific secretary of the European Myeloma Network. And he's now serving on the EHA scientific program since 2018. So welcome.
Thank you so much for your kind introduction. Here you can see my disclosures. And, well, I was here 7 years ago already in 2017. And yesterday night after dinner, I was looking at what I was discussing by then. And the topic of my talk in November 2017 was on naked antibodies, so daratumumab, isatuximab, ilotuzumab. I was discussing the recent results of Pollux and Kester, so Dara-Lendex and Dara-Veldex in relapsed refractory multiple myeloma. And we were discussing the newly diagnosed studies that incorporated a CD38 antibody. And look where we are now in 2024, where we are using Dara and Elo in different lines of therapy, and we are discussing a lot of new agents with novel modes of action, like the T-cell immunotherapies, the CAR T-cells, the bispecifics. And I also looked back yesterday night after dinner when we first started treating our patients with bispecifics. And in fact, our first patient that I treated in the phase 1 trial with teclistamab was treated in January 2019 with very low doses of teclistamab, homeopathic doses almost. And unfortunately, this patient A did not respond and died rapidly thereafter. But then in March 2019, we also gave a homeopathic dose intravenously to patient M. And this patient is still visiting our hospital, is still on teclistamab now 5 years later. And every year he brings, in fact, a very nice cake or pie to celebrate this very favorable outcome, which we did not have expected, actually. 5 years in a complete remission. And he's coming now to the hospital. How often? Not every week anymore, like in the beginning, but 4 times per year. So he gets his shot of teclistamab, whatever it's worth, maybe we should stop, every 3 months. And he's living a pretty happy life, except for, well, the previously, the bone disease that occurred prior to, this effective therapy. So this shows you clearly how fast progress in multiple myeloma is over the last few years. It's incredible, I think, especially when you compare it to diseases like leukemia or solid tumors. So today I will focus on T-cell redirecting bispecific antibodies. Very briefly, I will say something about CAR-T, because otherwise I will go over my time. I will discuss efficacy, I will discuss safety, and also something about resistance and how we can learn from resistance mechanisms to move forward. And then I'm thinking of combination strategies, for example. So here you see some bispecific antibodies that are now approved. We have Blina already for many years in acute lymphoblastic leukemia. It's also effective in lymphoma, but it's not approved in that setting. We have mosunetuzumab, we have glofitamab, epcoritamab in B-cell non-Hodgkin's lymphoma. We have tebentafusp in uveal melanoma. And of course, we will discuss here all the different bispecifics in multiple myeloma. So the bispecifics targeting BCMA and GPRC5D. So myeloma is characterized by profound immune suppression. There is an increase of bad cells in the marrow, Tregs, MDSCs, Bregs, that suppress immune function. And at the same time, there's a marked reduction in the number and function of normal immune cells, also T cells. So T cells are totally exhausted. They are reduced in numbers, so they don't fight myeloma so much. They're not able to keep myeloma under control. But good thing is that now, today, well, already since 5 or 6 years, we can help the T cells either by introducing a chimeric antigen receptor in the T cell, or by infusing or subcutaneously administrating a bispecific antibody. And a bispecific antibody binds with its CD3 part to the T cell, and with its other arm, it binds to a tumor-associated antigen, and then the T cell is recruited to the tumor, and the tumor is eliminated. So there are different bispecific formats. Here you see several of these formats. Blinatumomab is one of these small molecules which you have to give via continuous intravenous infusion, which is very cumbersome. You need central line, you get infections. And the first BCMA bispecific developed by Amgen, which was called AMG 420, was also a BiTE molecule, which was given, I think, 4 weeks on and then 2 weeks off, very cumbersome. And therefore, nowadays, we use this type of antibodies, which are larger. They have, for example, an Fc tail, and this Fc tail enables recycling via the neonatal Fc receptor, and thereby the half-life of these molecules is in the order of 10 to 14 days, and they can be given in a less frequent manner. So bispecifics in multiple myeloma often target BCMA, B-cell maturation antigen. BCMA, as you can see, is highly expressed on myeloma cells from relapse refractory patients, from newly diagnosed patients, but also on healthy donor-derived normal plasma cells. So also the normal plasma cells that are involved in antibody production against bacteria, viruses, express BCMA. And this is important to remember when we are going to discuss side effects like infections. And also it's expressed BCMA on B cells. We always said it is mature B cells, but in fact it's all the B cells in peripheral blood, as I will show you. So at this moment we have various bispecifics targeting BCMA in development. We have elranatamab, we have elnuctamab with 2 BCMA binding domains. We have teclistamab, we have ABBV-383, and we have linvoseltamab, and I've probably forgotten some, which are also in development, like the Harpoon compound. Overall, there seems to be not so much difference, I think, in efficacy between these bispecifics. They induce a 60 to 70% response rate, approximately 12 months of PFS, and at this time we have TEC and LRAN, EMA, and FDA approved. And I think you are busy with registration in your own country. Some differences do exist when it comes to results, and this is probably related to differences in patient population, the impact of the COVID pandemic in trials that started earlier versus trials that started later. And there are also some differences in terms of administration. Some are sub-Q, some are IV, some are given weekly from the beginning. ABPV is given every 3 weeks or 4 weeks from the beginning, so that might also be an advantage when it comes to patient preferences. So teclistamab is the first approved bispecific. It's giving a efficacy of approximately 62%. And what is remarkable for me is that all these patients either respond with a very deep remission or they don't respond. And you can see that only 3% of the patients achieves a PR. And in my experience, these partial responders are very short-lived responses. So it's either, well, it's a very black and white picture. And this is very different, of course, than what we have seen with IMiDs, proteasome inhibitors, CD38s, and so on. It's deep or nothing. And this translates into a very nice response duration, overall 22 months. And if you have a CR, it's even 27 months. And these patients are very heavily pretreated. Most of them were triple-class refractory, and they have received 5 prior lines of therapy. And the median PFS was 11 months, partly a bit lower than you would expect based on these response duration results, and this is because of the impact of COVID. There were several patients that not died of myeloma, but died of COVID. I think there were 11 patients in this phase 2 part of the study. And when we compare teclistamab with real-world practice, you can see that the blue line, teclistamab, is much better in terms of PFS than what you can do otherwise with IMiDs, proteasome inhibitors, cyclophosphamide, and so on. And also response with TEC was better than with real-world clinical practice. And based on this type of results, this type of comparisons, TECLI was approved in US and in Europe. Elranatamab is also approved in these countries based on 60% response rate. Again, very deep remissions, only few patients with partial response, and a very nice response duration and very nice progression-free survival. We also have bispecific antibodies in myeloma targeting other antigens. We have GPRC5D targeting antibodies, talquetamab, for example, also very effective in heavily pretreated myeloma with a 70% response rate for both recommended phase 2 doses. However, there is a marked difference when it comes to median progression-free survival. Weekly, 7.5 months, and every 2 weeks, 11.9 months. Maybe it's related to small patient numbers. Maybe it's related to subtle differences in patient characteristics. It may also be related to the fact that the every 2-week schedule allows for recovery of T-cell fitness, because you stimulate your T-cells less intensively with a more stretched-out administration schedule. But that's something that we have still to learn more about. And Forimtamig induces also very good responses, but we don't have yet the results for PFS. And then finally, we have bispecific antibodies targeting FcRH5, cevostamab, which is also effective in heavily pretreated patients with a 60% response rate at the higher dose levels. Bispecific antibodies have specific toxicities, and some of these toxicities are shared between the different bispecific antibodies and are irrespective of the antigen that's being targeted. And I have encircled those shared toxicities with a red square. And these shared toxicities are mediated by T-cell activation, which of course occurs with all the different T-cell redirecting bispecific antibodies. So we have cytokine release syndrome that occurs because of T-cell activation. We have ICANS because of T-cell activation, although this is quite rare. Infections are in part caused by T-cell activation and T-cell exhaustion. And I did not add here the tumor flare reactions, because with the bispecifics in multiple myeloma and probably also with CAR-T, we can sometimes see a tumor flare reaction. Who has seen a tumor flare reaction with a bispecific? Dr. Searle from Manchester has seen. So what do these patients present with? Severe pain in the lesions in the bone. And it's very predictable, right? It's very occurring rapidly after starting the bispecific. And these patients are sometimes very terrified that they are progressing straight away. So you have to comfort them that this is probably a tumor flare reaction. We do not need imaging, unless, of course, there is something atypical, like neurological abnormalities. Of course, then you need to exclude a progression of a plasmacytoma or something like that. So some of these toxicities are shared amongst all the bispecifics in myeloma, lymphoma, solid tumors, but we also have very specific on-target off-tumor side effects, and these are very different, and they are based on the expression of the target in normal tissues. And I will come back to these different toxicities in the next few slides. So cytokine release syndrome, when does it occur? It occurs very early, typically during step-up dosing. This is for teclistamab, or during the first full dose, and this is also true for elranatamab. And after step-up dosing, we rarely see cytokine release syndrome. Maybe when you stop for a long time and then restart, you can see it again, but also that is quite rare in my experience. So CRS, you probably know, is caused by T-cell activation. The T-cells are activated by the bispecific. They produce lots of cytokines, IL-2, interferons, and these cytokines in turn can also activate monocytes and macrophages, and they also produce lots of cytokines such as IL-6 and TNF-alpha, and altogether these cytokines may cause fever and also can cause endothelial permeability changes, leading to hypertension and sometimes hypoxia. And here you see the grading which we use in the clinic. One thing about ABBV-383, this is an interesting compound. It's not only interesting because it can be given every 3 weeks or 4 weeks from the beginning with similar efficacy as TEC and Elron and the others. But what is also interesting is that this compound has very low, relatively low CD3 binding affinity. And this leads to a more subtle activation of the T cells, less cytokine production, and this enables the administration of ABBV-383 without step-up dosing. So the patient doesn't get step-up doses, and they are only 1 day now in the hospital. However, with this regimen, your rate of CRS is still in the order of 60 to 70%, and they are trying to lower it with a more intensive dexamethasone schedule. But they want to avoid step-up doses to keep this, the administration of this drug relatively simple, because there's always shortage of beds in hospitals, probably also in the UK. Well, how can we prevent CRS? Well, of course, we do step-up dosing in most of the bispecifics, except ABBV-383, which is unique in that respect. We give pre-medication with DEX, with paracetamol, with an antihistamine, and we and others have shown that prophylactic tocilizumab also reduces the risk of CRS. It goes from 70% to only 26%, but you can also see that you still have a similar proportion of patients suffering from grade 2 CRS. So it lowers overall CRS, but you do not eliminate some of the patients which have grade 2 CRS, which is characterized by hypotension or hypoxia. So you have to admit these patients to hospital if you are thinking about outpatient treatment with prophylactic toci. When CRS occurs, there are different management techniques. In case of grade 1 CRS, which is most common, you can consider tocilizumab. In our hospital, we give tocilizumab very early on, as soon as CRS grade 1 occurs, because we want to keep admission as short as possible. We want to give the next dose of teclistamab as scheduled, and we also want to prevent escalation of grade 1 CRS to grade 2 CRS, which again is characterized by hypotension or by hypoxia, which is cumbersome, of course, for the patient. In grade 2 CRS, you have to give tocilizumab, and then steroids come into place when a more severe reaction develops. However, it's not bad to also give steroids instead of tocilizumab in case of less severe CRS cases, and don't give a more expensive drug like tocilizumab. I think Rakesh and you in UCL prefer DEX over TOSI, if I remember correctly.
Not always, but we can discuss that.
Yeah, we can discuss later. Maybe I misunderstood or I've mixed up other people. So this about CRS. I didn't discuss ICANS, but ICANS can occur in the setting of CRS, high fever, and mostly elderly patients with a more vulnerable brain can develop some headache or confusional state, but it's very rare to really have a full-blown ICANS picture. I have seen it only once in a patient with very high tumor load. And then let's look at the on-target of tumor side effects of bispecifics. So these side effects, as I mentioned, are related to expression of the target antigen in normal tissues. And when we discuss these on-target off-tumor side effects, I think infections are in part mediated by such on-target off-tumor side effects, at least when we discuss the BCMA bispecifics. So this picture shows you a little bit about infections in BCMA bispecific treated patients. Infections are very common in those patients. We see viral infections, we see respiratory tract infections, gastrointestinal infections, COVID-19, and all these infections continue to occur throughout treatment. And this is very different from what we see with other treatments, where the peak in infections is typically in the very beginning when tumor load is high. But here, you can see on the y-axis time, you can see that infections continue to occur. The only exceptions are infections with fungi, mostly candida infections of the mouth, and PGP. These infections seem to occur more early after initiation of treatment. So this also means that you have to remain vigilant and monitor your patients carefully and start antibiotic treatment early on to prevent severe infections or admittance to the ICU unit. So infections, we see them more with the BCMA bispecifics than with the GPRC5D bispecifics, and this is because the BCMA bispecifics have a more dramatic impact on the normal immune system. So what then do these BCMA bispecifics do? Well, on the left you can see that BCMA bispecifics eliminate normal plasma cells. I mentioned at the beginning, one of my first slides, that BCMA is also expressed on normal plasma cells, and indeed, they can be eliminated by teclistamab. I didn't mention, but GPRC5D is expressed on normal plasma cells at very low levels, and probably these normal plasma cells are spared when you give a GPRC5D targeting bispecific. And then on the right, you can see here what happens with the B cells. And also the B cells express BCMA, and you can see after cycle 3, complete elimination of the B cells in peripheral blood. So you eliminate all the B cells, you eliminate all the plasma cells, and this, of course, results in severe suppression of your humoral immunity with a drop in IgG over time, but also a drop in IgA, IgM, and this makes patients highly vulnerable to encapsulated bacteria, but probably also prevents neutralization of viruses. So this is what the BCMA bispecifics do, but I will show you later that this is very different with the GPRC5D bispecifics. So because we are totally ruining humoral immunity in patients treated with TEC, with Elron, with Linvo, I think it's very important to initiate IVIG early on, because otherwise these patients will develop severe infections. And this was, amongst others, shown in our hospital, where we looked at the patients that we gave IgG replacement from the very beginning as primary prophylaxis, or when we did not do that, but we only started IgG replacement when a patient had developed a severe infection. So this is reactive and this is prophylactic. And on the y-axis, you see the proportion of patients with a severe grade 3 or higher infection. So those are infections whereby the patient needs to admit it to hospital to give IV antibiotics or ends up in the ICU or dies. So severe infections, not a running nose. And you can really see after 12 months that there is a 15% severe infections with prophylaxis versus 65% severe infections without IVIG. And you can see the same difference when it comes to infection ratio, which is 10 when you compare prophylaxis and no prophylaxis. Of course, this is a retrospective study, so we probably need also prospective evidence of this intervention to make it possible to give this to all patients, because this is different from the way we give IVIG in Europe at this moment. Because the label is to start IVIG only after a severe infection, if the patient has hypogammaglobulinemia and is already using prophylactic antibiotics. So this is what GPRC5D targeting bispecifics do with the immune system. I mentioned already that GPRC5D is not so much expressed on healthy donor plasma cells, but it's expressed at high levels on myeloma plasma cells. And this explains that humoral immunity is going to be preserved when you treat a patient with talquetamab or with furintamab. And also GPRC5D is not expressed on normal B cells. So this explains why B cells are not eliminated. In fact, you can see after a while that B cells tend to increase, probably because the myeloma cells are gone and you can see some immune recovery. And also when you look at IgG levels with both the weekly schedule and the every 2-week schedule, you can see that IgG levels remain stable over time. Although when patients come in, most of the patients have already an IgG level below the normal, below the lower level of normal, because they have 6 or 7 years of myeloma, they have received many immune suppressive drugs, and of course the impact of myeloma on the normal immune system is also not a good one. So with talquetamab, we don't see this paralysis of humoral immunity, and that may explain why we see much more infections with the BCMA bispecifics than with the GPRC5D bispecifics. So much more infections with TEC and LRAN, especially severe infections, and less so with talquetamab and furintamab, and with sofostamab it's a little bit intermediate. And of course here you also have to take into account differences in follow-up. Longer follow-up means more infections. Also in a French registry we see a similar pattern, less infections with the GPRC5D treated patients and more infections with the BCMA bispecific antibody treated patients. So differences in impact on normal immune system translate into differences in infection rate. So how can we prevent infections in patients treated with BCMA bispecifics? Well, I've added here our local approach. We give growth factor support in case of neutropenia, and neutropenia is also quite common, especially after the beginning of a bispecific antibody, probably because of the local production of cytokines in the marrow, and can be seen with BCMA, GPR, and FcRH5 bispecifics. I give all my patients IVIG supplementation from the beginning, as soon as IgG drops below 4. But I don't do this actually in the patients treated with GPRC5D. I only do this with the BCMA bispecifics, because with GPRC5D, IgG levels remain stable, and I only initiate IVIG in my TEL-treated patients when they develop an infection or develop recurrent infections. And I give all my patients with BCMA and with GPRC5D valacyclovir to prevent against herpes infections, and cotrimoxazole to prevent against PGP. And here in the UK you have also seen that cotrimoxazole also prevents bacterial infections independent of levofloxacin. This was the team study. And further areas to explore are whether we can prevent infections by less frequent dosing intervals, allowing maybe for some sort of immune recovery, or by fixed duration treatment. I think this is 2 points that need a lot of attention in the future to make treatment with bispecifics less cumbersome. So I mentioned several times now that GPRC5D targeting bispecific antibodies spare humoral immunity, but GPRC5D targeting bispecifics have also other problems, because GPRC5D is also expressed in normal tissues, like in hair follicles, also in the tongue, in the filiform papillae, and also in cells that produce the nails. So in general, in cells that produce keratin. And this pattern of GPRC5D expression in normal tissues explains many of the GPRC5D related side effects that we may encounter after starting talquetamab or after starting furintamig. So what we see is skin problems, especially peeling of the foot soles and of the hand palms. This is one of my patients, and this typically occurs in the very beginning and disappears thereafter. And you can prevent this probably by using creams from the early, when you start treatment. And we also see nails changes, and sometimes the nails drop, and then a new nail develops underneath. And this is, of course, low grade when you score it according to your CTC AE criteria, but can be very cumbersome when you want to dress yourself, or when you want to do, well, small things in the household. Another problem with the GPRC5D targeting bispecific antibodies is that you also get oral toxicities, as I mentioned. GPRC5D is also expressed in the papillae in the tongue, and this may explain why many patients develop loss of taste or reduced taste. And in my hospital, we did a small study in which we looked at taste before and after 2 cycles of talquetamab, and you can see that total taste before was not super good in myeloma patients, because this is the dashed line is the limit to define good taste above and bad taste below. And you can see that the median is here, and after starting talquetamab, the median goes down substantially, indicating that all the patients had bad taste after talquetamab. And you can see that this is true for all the different taste domains. It's true for salt, it's true for sweet, it's true for bitter. However, we did not we did not examine umami. That's this new taste which is in soy. It's a Japanese taste, I think. And this will be investigated, I think, in a new study, which we are starting also together with Rakesh, the Talisman study, in which we are going to try to get more information on taste and oral toxicities to hopefully be able to mitigate this type of issues, which can be quite cumbersome for patients. Patients also complain of a dry mouth, and we looked at saliva production, but saliva production before unstimulated or with stimulation was similar before and after talquetamab. So the dry mouth feeling was not related to altered saliva production. So how can we tackle these GPRC5D related side effects? Well, I think the most effective intervention is in fact to reduce the dose or to increase the interval between talquetamab administrations. And in a small cohort in the Monumental 1 study, patients could dose reduce or could increase the dosing interval as soon as they had achieved a partial response. And the median time to partial response is only 1 month. So these patients had a more aggressive dose reduction strategy, and although they go rapidly to a lower dose, you can see that the response was similar to what you would expect from a more reactive dose reduction strategy. And here you can see that early dose reduction, the prospective dose reduction, was leading to a better resolution, an improved resolution of most of the GPRC5D related oral skin and nail toxicities, except weight. Maybe weight loss needs more time to recover, because some patients eat less because of this taste loss. and can really lose a lot of weight. And it's also important to keep an eye then on blood pressure medication, on diabetes medication, if appropriate. I had a very big lady, and she was super happy with talquetamab because she had to go, she could shop every month, a completely new attire. Now she's on BCMA. So how to move further? Well, I think one of the interesting domains to further improve myeloma treatment is, of course, to combine bispecifics with other agents. And I find it always very helpful to find rational combination strategies by looking at resistance mechanisms. And here in this cartoon on the right, you can see the diverse mechanisms of resistance to bispecifics. Patients may not respond or may develop resistance because of the microenvironment that's highly immune suppressive, or because of tumor-related features, or they can develop progression, or they do not respond because of T-cell associated features. And I will, in the next few slides, briefly discuss some of these resistance mechanisms which have informed us about better combination strategies. So regulatory T cells are present in the bone marrow microenvironment, and they can inhibit T cell responses. The interesting thing about regulatory T cells is that they also express CD3 on the cell surface. So one of the questions was that we wanted to answer in our lab: what happens with a regulatory T cell when we add a bispecific antibody? So we isolated in our lab regulatory T cells in green. We also isolated CD4 effector cells in red, and we showed that, as expected, regulatory T cells could suppress effector cell proliferation. And we also showed that regulatory T cells, when they were redirected to the tumor by a bispecific antibody, in this case talquetamab, were able to lyse myeloma cells, 30% here and here 40%, but they did so less effective than the CD4 effector cells, 60%, and here 70%. We also showed in blue that when you add regulatory T cells to your effector cells, that lysis is impaired. And on the right, you can see that regulatory T cells do not produce interferon gamma, that if you add them to effector cells, that they impair interferon gamma production, and the same is true for TNF-alpha, for IL-2, and also granzyme B production was impaired when you add regulatory T cells to effector cells. So this type of preclinical experiments, lab experiments, shows that CD3 expressing regulatory T cells can be redirected to the tumor. They can kill a little bit, but the most important thing is that they impair proliferation, impair lysis, and impair cytokine production of the good ones, the CD4 effector cells. This is lab work, but also in clinical studies. We and others have shown that patients with high numbers of regulatory T cells are more likely to not respond. So this is non-responder and this is responder, and you can see that they have a higher level of Tregs in blood and also a higher level of CD38 positive Tregs in blood and also in marrow. And here you can see that patients with a higher than median number of regulatory T cells have a much worse progression-free survival than those with a low number of regulatory T cells. So what can we do with this type of information? Well, we have shown that daratumumab is able to eliminate the CD38 positive Tregs. So why not combine a bispecific antibody with daratumumab to improve your bone marrow microenvironment, to remove the immune suppressor cells? Not only Tregs are eliminated, but also Bregs and MDSCs, because all these cells express CD38. And indeed, in the lab, we have shown that T cells from patients that are DARA exposed in patients, blue, are better killers than daratumumab-naive T cells from the same patient. So the curve shifts upwards and to the left. And this was true for teclistamab, and this was also true for blinatumomab. So daratumumab can improve the lytic capacity of T cells, probably by eliminating the bad guys of the immune system. So the Tregs go down after dara exposure. And we already know from clinical studies that adding daratumumab to a bispecific antibody can be effective. Early results from the phase 1b TRIM study shows that adding daratumumab to talquetamab leads to a very promising median progression-free survival, which was not yet reached with the weekly TEL schedule, and it was 19 months with the every 2 weeks TEL schedule. And this is especially interesting, I think, when you consider that more than half of these patients had previously been exposed to anti-BCMA, and almost all these patients were anti-CD38 refractory, so had been exposed to daratumumab or isatuximab before. And now the MajesTEC-3 study is further investigating TEC with DARA in DARA-sensitive patients versus standard of care. And there is also a study in which, phase 3 study in which DARA is combined with TEL, ongoing at the moment. So I discussed the bad impact of the suppressor cells in the immune microenvironment, but patients can also develop progression because of tumor-related features. For example, tumor cells can have very low expression or can have absent expression or may acquire loss of the target antigen, leading to progression. And we are getting more and more information on this type of antigen escape. This is, for example, data from the Canadian group, which showed that patients treated with a BCMA bispecific can lose BCMA expression because of biallelic BCMA loss or because of mutations in the extracellular BCMA bispecific antibody binding domains, or a combination of both. And on the right, you can see that also with GPRC5D, we are seeing now patients relapsing because of GPRC5D loss, either because of biallelic GPRC5D deletions, or because of mutations, or again, a combination of the deletion and a mutation. So how can we prevent antigen escape? Well, we can prevent antigen escape by targeting at the same time two different myeloma-associated antigens. And that's why in a different study, teclistamab targeting BCMA and talquetamab targeting GPRC5D were combined, and this combination of two bispecifics led to very promising response rate, especially in the setting of extramedullary disease. In this setting, we see at the recommended phase 2 dose a 85% response rate, and this is much higher than what you would expect with teclistamab alone or talquetamab alone, because when you treat patients with extramedullary disease with TEC, you see a 30% response rate, and a similar response rate of 30% you see with TEL alone. So this is more than what you would expect. And also the median PFS of 10 months is much longer than the 3 or 4 months than what you would see with either agent alone. So maybe in the future, we will use a combination of two bispecifics in specific subgroups with very high risk of antigen escape or specific mutational profile that makes them prone to develop antigen loss. For example, deletion 17p carries a higher risk of developing BCMA loss. And finally, I mentioned already that also T-cell related characteristics can lead to non-response, primary resistance, or can also contribute to acquired resistance. It's not only T-cell fitness, it's also T-cell frequency that is important. And in the lab, we have shown, for example, that when you increase the number of T-cells, then you can improve your response substantially. Both with teclistamab as with talquetamab, you see dose response shifting to the left when you improve your effector to target ratio. And this is not very surprising. And this is also seen in clinical studies where T-cell numbers matter. So here you see a higher T-cell count in responders to teclistamab, both in terms of frequency as in terms of absolute counts. Responders have more T-cells than the non-responders. But it's not only the frequency, it's also the quality of the T-cell that is relevant, because in this study it has been shown that patients that do not respond have a higher frequency of T-cells expressing PD-1 or expressing TIM3 or expressing the activation marker CD38. And CD38 is not only an activation marker, CD38 is also a molecule that is involved in immune suppression by being involved in the local production of adenosine, which impairs T-cell function. So T-cell fitness at baseline seems to be relevant when you are considering a patient for bispecific antibody treatment. But T-cell fitness may also be affected by bispecific antibody therapy because with the bispecific antibody you are continuously activating T-cells, and this continuous activation of T-cells may lead to T-cell exhaustion, so reduced T-cell fitness. And a reduced T-cell fitness over time may also contribute to the high rate of infections that we see, but may also contribute to relapse. So in our lab, we have looked at the blood of patients treated with bispecific antibodies, and we harvested blood at baseline, after 2 months of bispecific antibody treatment, after 10 months of bispecific antibody treatment, and at the time of progression. And you can see that both in CD4 cells and in CD8 T cells, you see an increase in checkpoint inhibitors, in PD-1, in TIGIT, in TIM3, but to a lesser extent. And an increase in checkpoint inhibitors may be associated with exhaustion, but when T cells get activated, they also increase expression of these inhibitory molecules. So it's always the question of whether this profile is reflecting T cell activation, or is this reflecting T cell exhaustion. However, we know from chronic infections, hepatitis C, HIV, that when these molecules are upregulated for a prolonged period of time, many months, like in this case, then it's more likely to reflect T cell exhaustion. So to further investigate this phenomenon, we also looked at functional characteristics of these T cells. And what we did was that we stimulated these T cells from patients, for example, with CD3, CD28 beats, or we stimulated them with TEC and TEL in the presence of a myeloma cell line. And you can see, for example, here with the CD8 T cells, that bispecific antibodies reduce T cell proliferation, most pronounced at the later time points, but already present after 2 months of teclistamab or talquetamab. So T cell proliferation goes down when you use beats. And we also found that the killing capacity of the T cells was reduced when you are activating, stimulating these T cells continuously with a bispecific antibody. So here you see, for example, at baseline, that myeloma cells were killed by 75%, and this goes down to 50%, and this was even more pronounced at the time of progression, where the T cells kill only 20% of the myeloma cells. So this increase in inhibitory molecules leads to less proliferation, reduced killing capacity, and also cytokine production and granzyme B production went down after continuous exposure of the T cells to bispecific antibodies. And here you can see, for example, with IL-2, that also early, but also later, IL-2 production is severely impaired after chronic exposure of the T cells to a bispecific antibody. And you can imagine that this different functional profile of T cells may contribute to infections, viral infections, but may also contribute to relapse because there is less control over the residual tumor cells. So how can we, in theory, improve T cell fitness, or how can we prevent T cell exhaustion? I think the IMiDs, the CellMods, are potentially interesting in this respect. Laboratory research has shown that CellMods and IMiDs can prevent T cell exhaustion, probably by providing T cell co-stimulation. And early results from Monumental 2 also show that POM plus talquetamab is a promising combination strategy with, at the weekly TEL schedule and every 2-week TEL schedule, a 93 or 84% response rate in patients that were quite heavily pretreated, 3 prior lines of therapy, but only few of these patients were POM refractory. So most of these patients had never seen pomalidomide. But what is interesting is that the 9-month PFS rate, I think, looks very good, 93% with the weekly TEL and 75% with the every 2-week TEL schedule. And we have to learn more about this combination with longer follow-up, but I think this could be an interesting combo, whereby also the hematologic toxicity was not exacerbated over and above of what you would expect with either agent alone, which was probably different when you add a pomalidomide to teclistamab. I think we see more neutropenia in that setting. How can we further improve? Well, we also know that T cell fitness is better in newly diagnosed patients, and that's why the EMN study group started the EMN 30 study, in which we are going to try to improve the prognosis of patients with newly diagnosed myeloma by giving them either TEC or TEC plus len, and compare this to lenalidomide maintenance after transplant. So patients get induction, transplant, and then with or without consolidation, one of these 3 different maintenance regimens. And the idea is here that earlier lines are associated with better T cell fitness, and we also know that a lower tumor load, which optimizes your effector to target ratio, may improve the efficacy of your bispecific antibody. So rational sequencing instead of using random combinations of drugs following up each other. Also with elranatamab, there is a study ongoing, the Magnetism 7 study, in which maintenance lenalidomide will be challenged by elranatamab as a monotherapy. And then the Boston group has shown at last ASH meeting that also high-risk smoldering myeloma can be effectively managed with teclistamab. We will discuss later today whether this is a good thing or a bad thing. But patients with high-risk smoldering multiple myeloma had a 100% response rate with teclistamab, and 83% had a CR, 17% had a VGPR. These patients will probably develop a CR with longer follow-up, because we are looking probably here at the long half-life of the M protein, because all these patients that were response evaluable, 12, developed MRD negativity at the level of 10-6. So very deep responses with teclistamab in an early setting. But we can discuss whether this is a good thing. Are we over-treating patients that will never have developed myeloma if we had left them alone, and we are only exposing these patients now to infections, or are we really preventing disease progression and improving their survival? Then here you can see an adaptation of the EHA-ESMO guideline of how to treat patients with triple-class refractory multiple myeloma. Now, with the recent approvals of CAR T cells in Europe, the approvals of bispecifics in continental Europe, we are now treating these triple-class refractory patients very differently than we did in the past, when we were only able to recycle drugs that were given before in a different combination. I've never given selinexor, I have to admit. I've never given melflufen, I have to admit. And I've never given any patient belantamab mafodotin, I have to admit. But I like now we always recycle drugs given before, but because we did not have access to these. But now we have access to bispecifics in compact use programs, and many patients are now getting those agents also outside of clinical trials, although I still favor, of course, enrolling these patients as much as possible in new trials with novel strategies, which will probably further improve upon what we have today. Do I still have some time, or am I over? A couple of minutes, then I will be fast, because I was asked by the organization to also briefly mention CAR-T. Well, bispecifics are very effective T-cell redirecting agents, but we also have CAR-Ts, and CAR-Ts have as a big advantage that they are a one administration treatment. We see a slightly higher severity of CRS, we see a little bit more ICANS, but the good thing about CAR-T is that it's a one shot, and then the patient is free of therapy for a long period of time, and we learned from last ASH meeting that this is really translating into superior, very promising improvements in quality of life. And now, today, that we have different agents targeting BCMA, we have different T-cell redirecting therapies, we also have to think more and more about the best sequence of these drugs, and that's the last 2 or 3 slides of my presentation, to briefly address the difficult topic of sequencing therapy in the setting of T-cell immunotherapy, in the era of T-cell immunotherapy, because one therapy can have an impact on the next treatment by impacting the immune system in a good way or a bad way, by impacting antigen expression, for example, inducing antigen downregulation or antigen loss. You can also induce resistant myeloma clones, and then the mode of administration of the drug has probably an impact on all these different aspects. So how should we ideally sequence CAR-T cells and bispecifics? Well, there is some data now that CAR-T after bispecific antibody is maybe not the best idea, although these studies enrolled very few patients. Some of these did not respond to previous BCMA-targeted therapy. So it's very difficult to really draw conclusions, but from all the different studies, it seems that CAR-T should be given earlier than bispecific, if you want to consider both agents in an ideal world. So in the CARTITUDE-2 study, response of cilta-cel after prior bispecific antibody or after prior ADC was only 60%, while it was 100% in CARTITUDE-1 in BCMA naive. And also the progression-free survival was only 5 months and 9 months after prior bispecific antibody and prior ADC, while PFS was 3 years with cilta-cel in BCMA naive patients. So cilta-cel after prior BCMA seems to impair its efficacy and is maybe a waste of money. There is, however, a lot of evidence that bispecific antibodies can be effectively given after CAR-T. So maybe in the ideal world, you should consider this information. However, access to CAR-T cell therapy is limited. There are reimbursement issues, manufacturing failures, and often rapid disease progression, which makes CAR-T application very difficult. So maybe we can now start bispecific antibody treatment in these patients, but harvest the T cells before so that we can make CAR-T cells later on. Maybe you can use an alternative therapy with different mode of action between both BCMA-targeted therapies, because there is information that the treatment-free interval, a BCMA-free interval, improves efficacy of CAR-T cells when they are given after ADC or bispecific. Or maybe we can give CAR-T cells with a different target after a BCMA bispecific antibody. And in the future, maybe this problem will become less prominent, because we will be using bispecifics as a fixed duration treatment, and we can give CAR-T cells also in rapidly progressing patients because of new manufacturing techniques that allow rapid CAR-T manufacturing, or by using allogeneic CAR-T cells. And finally, we also have to learn more about sequencing of bispecific antibodies now that we have bispecific antibodies in myeloma that target different tumor antigens. And prospective studies with small numbers of patients have already shown that we can sequence bispecific antibodies, but it seems that the activity of the second bispecific antibody is reduced compared to bispecific antibody-naive patients, and this is probably related to T-cell exhaustion or maybe selection of T-cell resistant clones. And here you see, for example, what happens when you give talquetamab after BCMA bispecific antibody. You see that the response is quite good, 64%, but your PFS goes down to 5 months, while it was 8 months and 14 months in patients that had never seen a bispecific antibody before. And that brings me really to my conclusion. I think I showed you today that the T-cell redirecting bispecific antibodies, but also CAR-Ts, are transforming myeloma treatment because of their high activity in highly refractory multiple myeloma patients. I also showed you that appropriate supportive care is very important, especially to prevent severe CRS or infections. And I showed you some examples of how a better understanding of resistance mechanisms has already resulted in novel strategies that have the potential to improve depth and duration of response, and various large phase 3 trials are currently ongoing to prove this type of novel concepts. Thank you for your attention.
Thank you very much, Niels. That's a fantastic overview, both of the science but also of the practicalities as well. Can I just remind those online to post any questions on the Q&A on the chat, please? Any questions from the audience here, just whilst people are typing? Carrie.
Thanks, Neil. Great talk. You mentioned that the BCMA bispecific responses are usually very deep, so CR or VGPR being very common. In your experience, what's the situation with GPRC5D? And if the responses aren't as deep, do you think that's anything to do with the lower impact on normal plasma cells, or perhaps the MGUS-like clones secreting and giving it a lesser response?
Also with the GPRC5D bispecifics, I think most of the patients achieve a deep remission, VGPR or better, and the ones that have a PR and don't have further deepening of response over time, in my experience, are the ones that develop early progression. So I have not seen patients with PR with prolonged MGUS-like behavior. Maybe in the future we can intervene. That's also a possibility. If we see that response doesn't deepen further, remains PR or remains minimal response, maybe we have to add something to boost T-cell fitness, maybe a checkpoint inhibitor, maybe an IMiD, maybe a CELMoD. So that could also be a strategy to not combine the drugs from the very beginning, but do this in patients that are not evolving rapidly into a deep remission, which is needed for a prolonged response.
Thanks.
Thank you. There's a question online, and it's probably an impossible question, but if you could only have access to one bispecific antibody, which one would it be?
Well, I think there are now so many. For the BCMA bispecifics, I don't think there is so much difference in efficacy, not so much difference in safety. I think they are pretty much giving the same balance, with some differences in sub-Q or IV administration, weekly versus every 4 weeks from the beginning. And I think, well, if you are familiar with one, I think that's also important, because then you don't make mistakes. That you don't skip one step up and give the wrong step up and end up with severe CRS, which happens actually in my hospital once. We forgot the first step up and we gave the second directly, and this patient in a compassionate use program developed severe and prolonged CRS very early on. And so I think that's also important, that the doctor knows all the details on the administration schedule to prevent mistakes. And then, well, maybe the question is also BCMA or GPRC5D. I think I have patients that have a history of infections. For example, patients with chronic obstructive pulmonary disease, asthma, COPD, and these patients are typically having recurrent infections with the BCMA bispecifics, and then I would prefer to start a GPRC5D bispecific earlier in these patients, with good experience up to now. For example, I have a patient in my mind that has COPD. I started with talquetamab, and he had no infections. At time of progression, I had to move to teclistamab, and he had a miserable couple of months, and I had to stop the BCMA bispecific despite all the interventions that I did, going to high IgG levels and so on. I stopped teclistamab, and now he has a treatment-free interval already 1 year, I think, and now he's back to a very good quality of life. So hopefully he will enjoy that longer. So GPRC5D I prefer in patients with a history of recurrent infections. Otherwise, I think I prefer to start with the BCMA bispecific.
And just following on from that in relation to infections and efficacy as well, you talked about the concept of T-cell exhaustion and potentially increasing the time interval between doses, and then there's also having fixed duration. If you, I'm asking to speculate, but if you had to kind of extrapolate as to what you think would be the most effective way at maintaining effective disease control and at the same time minimal infection, which do you think is probably more important of those two?
I think that's the golden question. The very important issue. I have to in Qui and also Emma, we go to IMS. That's my talk there, the optimal duration of treatment. And I think we need studies, in fact, to really inform us about fixed duration treatment, to inform us about maintenance strategies, and hopefully in the future we can identify patients which are able to stop for a very long period of time and benefit from a prolonged treatment-free interval. I have one patient in my clinic which developed in the early days severe sepsis. He had to stop teclistamab after 1 year, and he's now in a complete remission already 3 years of therapy, which is amazing, of course, when you consider that this patient had continuous therapy during the rest of his myeloma life, during the previous part of his myeloma life. So I think the key question is, how can we identify patients that benefit from a treatment-free interval? Is it the immune profile? Is it MRD? Let's see.
Thank you. Any last questions from the audience? No. Well, thank you very much for your presentation. It's fantastic. We've just got a little presentation for you as well. Okay, so thank you. That's a really fantastic overview. We're going to now move on to some more debates. The next session is really going to be around treatment versus, early intervention in terms of treating at biochemical progression or at clinical progression in patients with relapsing myeloma. I'm going to start with a case, and then we're going to do a vote. So this case is of a 60-year-old man who presented originally to his GP, to a spinal orthopedic team with thoracic back pain. MRI spine revealed a destructive lesion at T9 with a soft tissue component replacing most of the vertebral body and the right side of the pedicle, with a further area of replacement at T6. Baseline bloods revealed hemoglobin 127, renal impairment with a creatinine of 174, hypogammaglobulinemia, and very elevated free kappa light chains of over 8,000 milligrams per litre with a ratio of 6,000. Remainder of the staging revealed high beta-2M and an albumin of 50. Bone marrow confirmed the diagnosis of myeloma with 60% malignant phenotype plasma cells, but no evidence of high-risk FISH. And the CT chest, abdomen, and pelvis with skeletal survey confirmed the 2 known thoracic lesions, plus another small additional lytic lesion in the left humerus. So the patient was treated on the Myeloma 11 Plus trial with KCRD induction, achieved a complete response post-induction, and had an autologous stem cell transplant and remained in CR, and actually, a bit like the case earlier today, was randomized to no maintenance. 3 years later, he started to develop asymptomatic rise in the free kappa light chains. It's gone from 19 to 50 to 100 over a 6-month period with a lambda of 7, so a ratio of about 15, something like that. Had a repeat whole body MRI with no new lesions identified. And that just demonstrates a very dramatic initial early response, and then you can just start to see a slight creep towards the end. So in summary, this is a 60-year-old man presented originally with acute kidney injury and bony disease at diagnosis with light chain disease, standard risk FISH, ISS 3, achieved a CR post-induction, post-auto, and now has evidence of biochemical relapse, gradually rising serum-free light chains. Is now 3 years post-auto, not on any maintenance. So the questions we have for you now are, what are the best options to either start second-line treatment now? You would have already started treatment before we got to a ratio of more than 100, a difference of more than 100 rather. Repeat the bone marrow and genetics, or just close observation and serial re-imaging. So I think if you can get your devices out and answer one of those options, 1, 2, 3, or 4. Second line treatment now, you would have done it already. Repeat the marrow and genetics, close observation, and repeat imaging. Just give it another 5 or 10 seconds. Okay, let's see what that shows. Okay. So there we go. So already over 50% have suggested just close observation and serial re-imaging. About a third have repeating the marrow, undertaking repeat FISH to see if there's any clonal evolution, and then about a sixth will start treatment now, and very few would have actually already started treatment at this stage. So let's see what influence next two speakers have. I'm going to introduce both speakers now so we can go back to back. So first of all is going to be Charlotte Paulin, who is a CRUK scientist that I'm sure you'll know very well, working at the ICR and a consultant haematologist at the Royal Marsden. She leads the myeloma biology and therapeutics team there at the ICR, focusing on new therapeutic targets to improve outcomes, including IMiD resistance and high-risk disease. She's also very actively involved in a number of myeloma studies in terms of being a member of the TMGs, as well as being closely involved with myeloma 11, myeloma 14, and is actively designing, as you've heard this morning, on the IFIT, which is the new frontline elderly study. And then followed by Charlotte. So Charlotte will be talking about treating early, and Emma will be giving the opposing argument. So Emma trained in Manchester, also along the way gained an MA in medical ethics and cancer and palliative care, and has also been awarded the CRUK PhD fellowship, which she completed in 2016. She's now a consultant haematologist at the Christie in Manchester, with a particular interest in early phase clinical trials of a range of novel anti-cancer drugs, so actually not just in myeloma, but also in AML, and is actively involved in a number of early phase studies. She's also the deputy chair of the Experimental Cancer Medicine Centre Network Group, deputy chair of the BSH Research and Grants Committee, and a member of the AML and steering group and the UK MRA as well. And she was also awarded an Early Career Researcher Award in 2023. So over to you, Charlotte, first of all.
So thank you very much to the organisers for inviting me, and thanks to all of you for voting very low on my side of the argument to start with, because I see that as an easy win. I only have to persuade a few people to change their mind, and I can switch those ratios around. So yeah, my side of the argument is to treat this case early. So we have achieved biochemical progression, and we therefore, I would argue, should be treating this patient. These are my disclosures. So just to get the terms correct in terms of what the arguments are, so if we don't treat it biochemical progression, the only other truly measurable point at which you can decide to start treatment, I would argue, is the point of clinical relapse. So the point of clinical relapse is the point at which Emma's going to let her patient become hypercalcemic, develop a bone fracture, become anemic and need a transfusion, or particularly in the case for this patient, perhaps develop worsening renal failure as they had at their initial diagnosis, or even maybe some more aggressive phenotypes like extramedullary disease or plasma cell leukemia. In contrast, biochemical progression is something we can measure. We can measure it early. We know the definitions that I won't read through but are laid out here are the definitions of biochemical progression. They're the endpoints of clinical trials, the point at which we say a treatment is no longer working for a patient, and the point at which, importantly, in a clinical trial, we definitely shouldn't treat before this point, because otherwise we can't record progression and then record progression-free survival within the trial. And I would argue that identifying biochemical progression and then intervening is the whole point of seeing all of our patients so regularly in myeloma clinics. So we see them every month or every 2 months. Specifically so, we can see these small changes from an undetectable paraprotein to perhaps a paraprotein of 1, 2, or 3, and then detect that point at which they reach IMWG biochemical progression, and therefore, I would argue, require treatment. And so what are the benefits of treating at that point rather than waiting till clinical relapse? So we treat it biochemical progression. The patient is hopefully feeling well, has a good performance status, a good organ function, a smiley face. If we wait until clinical progression, the patient's probably feeling quite unwell. Their performance status may be dropping. Their organ dysfunction might, in fact, limit what treatment options we can deliver, and therefore they have a sad face. But Emma might argue that even if we don't treat it biochemical progression, we may not need to wait until clinical progression to treat. So she'll tell you that you can just monitor, and we'll keep a close eye, and we'll watch those numbers, and then we'll decide what we can do. But I'm hoping that she's going to tell you that she's got some special skills to do that, because I would argue that there is no other point at which you can tell what is going to happen to your patient. You've got either biochemical progression or you have to become Mystic Emma. For those who did not grow up in the 80s and 90s, Mystic Meg may be unfamiliar to you, but hopefully by the laughs it is familiar to some people. So we don't all have a crystal ball, so we can't all tell at what point, at what precise light chain level, at what precise paraprotein level that end organ damage is going to occur. And so when we're monitoring patients in clinic, we're just waiting for something to happen, and we're trying to do something before it happens, but we don't know when that's going to occur. And apart from struggling to predict the future, we're also leaving patients with this sense of anxiety about, we have said, oh yes, you've reached biochemical progression, particularly for patients in clinical trials. At that point, we will have stopped therapy, but we don't think you need treatment at the moment. They're thinking, well, but when? When will I need treatment? And so we maybe set some arbitrary limits. We maybe say, oh, when your paraprotein's 10, when your light chains are 500, but we don't know that harm won't happen before that point. And so for one of my arguments, you can think of it as this boiling frogs metaphor, which is about increasing the temperature of water or the conditions around a person. Maybe the patient will start to feel more unwell, but adapt to those new symptoms. And if they had suddenly got all of those symptoms, like the frog going into boiling water as opposed to going into gradually warming water, if they'd suddenly experienced those new symptoms, they would have wanted to change treatment at that point. And often we hear from patients when we do start treatment, oh, I do actually feel better now, thank you. You know, actually this has made a difference to those subtle symptoms that I perhaps couldn't put my finger on or weren't shown in the light chain or paraprotein results. Importantly, I'm going to bring some science into my argument. So if we think about what we understand about clonal evolution in myeloma, then if we know that the tumor is going to evolve over time and become increasingly more complex, perhaps with increasingly more drivers of resistance to different therapies, if we start treatment at one of these earlier time points, the tumor will be less complex and therefore potentially easier to get under control. Apart from science, I also have some data. So this is a study that specifically looked at patients who either had biochemical relapse, which was about 60% of patients, or clinical relapse, which was 40% of patients. And this first analysis was looking at the time until they needed next-line therapy. So you can see that those patients who had biochemical progression, the blue line, had a longer time until they needed next line therapy compared to those who had clinical progression, and that this is marked out by those with clinical progression by CRAB in green or by aggressive characteristics in red. And maybe you might be concerned that that might represent some kind of lead time bias. If we're starting treatment early, they obviously won't. It will be longer until they might need the next line of therapy. But I can counter that, in case Emma tells you that, by showing you that the overall survival analysis of that same study showed a clear and even greater benefit for treating biochemical progression compared to clinical progression. I'm not going to go through any other studies, but just to point out there are several other studies that have looked at this exact same question and found essentially the same answer. So in summary, my arguments are to treat at biochemical progression, to prevent end organ damage, keep patients feeling well, try and attenuate the anxiety in both the patient and the clinician from watching and waiting, to try and limit clonal evolution, and because it's supported by the data. Thank you.
Very much, Charlotte, and I particularly appreciated the Mystic Emma slide for reasons that will become apparent. So, the case for monitoring. Now, here's my conflicts, not as long a list as Charlotte's. As Matthew kindly mentioned at the beginning, this is my regular home. This is the clinical trials unit at the Christie Hospital. And this is where I spend most of my week looking after patients in clinical trials. And when we were discussing this debate yesterday over dinner, my learned colleague, Jam, in Oxford, said that I was the least obvious choice to defend the position of waiting until clinical relapse due to the fact that I do clinical trials. Now, I don't know what he meant. I can only assume he thinks that I view every patient as a guinea pig. Just wait, and I'm just keen to get them into that clinical trial as quickly as possible. But in the coming slides, I will convince you that not intervening early is the right thing to do. And that's because it's not based on evidence, whatever Charlotte and all her sign trying to bamboozle you with science try to claim. It's financially irresponsible. And it might harm the patient. So I knew that Charlotte was going to wheel out this paper. And it does sound, it sounds impressive, doesn't it? Look at the key points here. Patients with multiple myeloma after clinical progression have inferior survival compared to patients with multiple myeloma after biochemical progression. And these, if I was a patient reading this paper, I'd be really alarmed. Median survival, 60 months in those with biochemical progression being treated versus 26.2 months in those with clinical progression. But I would make the point that Charlotte is muddling up her chickens and her eggs. What do we know about patients with clinical progression as their first presenting feature, their first indication to treatment? Well, they probably have a more aggressive disease phenotype. And so all that Charlotte is telling me is that patients with an easier to treat myeloma may respond better to intervening in their therapy. And I spent a long time arguing this points with a medical monitor for one of my clinical trials. Here's the inclusion criteria. As Charlotte pointed out, a lot of our clinical trials put this huge emphasis on biochemical progression. And some of you who are in the audience who don't spend as much time battling with medical monitors as me will be very surprised to hear that, in fact, clinical progression no longer counts. So we were discussing a patient who had broken through his current line of therapy with malignant hypercalcemia, had to be rescued with some high-dose steroids and other treatment, not eligible for the clinical trial because he's only got a modest rise in his urinary free light chains. Therefore, apparently, his myeloma has not progressed. And if we look at all of the seminal studies, and I don't expect you to read all of this, that has really, forms the framework for the treatments that we use. What we discover is if we look at the percentage of patients with biochemical progression compared to clinical progression, well, we can't actually see what those proportions are. Now, I've already told you that clinical trials have a hyperpensity, so only enrolled biochemical progression. But, you know, the comparison is not possible. So the column on the right here is percentage of patients with biochemical relapse, unknown, 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 unknown. This makes the point again. So why is it that in none of these clinical trials that inform what we do, anyone is willing to look at the differences in how patients get on, depending on whether they have biochemical relapse or clinical relapse? Well, I'm not a conspiracy theorist, but this might be one argument. So it's not really in the interests of the pharmaceutical companies to demonstrate that we need to use their drugs later. And I've got a very similar slide to Charlotte in my slide deck here. Charlotte is an extremely capable clinician and scientist. I'm not sure about her predictive powers, apart from guessing what might have been in my slide deck. But if I can take you back to the patient, we always have to think about the patient in these cases, don't we? And it's all about an individualized approach. So when his myeloma was symptomatic, he had kappa light chains, involved light chains of over 8,000. He's just miles off. Do we seriously think that we should intervene at this time point? And those two papers that Charlotte also quoted that look specifically at patients relapsing after frontline autograft, both bone marrow transplantation papers, recognized that the median time between biochemical and clinical relapse is 5 to 6 months, and a quarter of patients with biochemical relapse do not show symptomatic progression after 2 years. And can I also remind you all that, you know, as Neil's already showed you in his talk, you know, the thing that drives progress and drives improvements in outcomes in multiple myeloma is the development of novel agents. So Charlotte is basically proposing that you give an already outdated treatment to this patient rather than waiting a couple of years and having something better to offer. So for the horticulturally minded in the audience, does anyone know what this is? Anyone? This is a money tree. Now, they're a very beautiful houseplant. I believe that, you know, it's felt that if you put them in your home, in your office, then, you know, it will bring in good luck and fortune. But they don't actually grow money. And as we all know, the £350 million a week additional NHS funding that we were promised by our Prime Minister at the time, Boris Johnson, hasn't materialised. And, you know, these are expensive drugs. I don't know what Charlotte had in mind for this outdated therapy Charlotte had in mind for this patient. But, you know, daratumumab, £4,320 a dose, and you're going to give that weekly. Bortezomib, I mean, we all think this is cheap now because its patent is finished, but it's still £500 a dose, and Charlotte's presumably going to give that once or twice a week. I've left the decks off. We'll let her have that one for free. So, and then, of course, let's consider if we are proposing that this patient needs to be exposed to daratumumab and Velcade. Let's revisit the New England Journal of Medicine paper that introduced this as a standard of care treatment. Grade 3 to 4 reverse events, 76.1% of patients. Now, I spend a lot of time with my nose buried in the CTCAE grading system, let me remind you that that means these patients might need to be hospitalised. This is not what we want for this man, who is currently living quite happily in the community, not on any treatment. And death was reported in 5%. Now, I'm a big fan of a visual abstract. So here, as promised to Charlotte last night, are my 4 pictures to remind you why this man does not require treatment. Thank you very much.
Actually, if you want to come and join us up here for any questions we have just before we do the voting again. You have to vote first? All right, we can vote first, I don't mind. Can you vote first? Okay, let's vote first, before anyone gets any more biases, because actually I want to ask some questions which might bias things. So let's go back to the question again. So it's just about to come on the screen. So yeah, if you want to log back in again and then see if your answers have been influenced at all by the debate. So just to remind, what's the option now? This is someone relapsing 3 years post-auto with biochemical progression. So start second-line treatment now. You would have started it already. Repeat the marrow and genetics or close observation and further imaging. A couple of people just changed their mind. But okay, I think we'll stop there, and we'll see what the results show.
Not much change the mind at all.
So it hasn't hugely changed, but I think actually more people are, so slightly more are doing close observation. I think that was about 50% before, wasn't it? So it has gone down slightly in terms of the interventions, either imaging, either bone marrow or starting treatment now. Okay, let's give you a chance to answer any questions. Particularly the one I want to ask is about you both presented the same data and interpreted it differently, which is obviously commonly the case. You mentioned, Charlotte, about the lead time. In that study, and I haven't looked at it in detail myself, did they go back and look at the patients who they classified as having symptomatic disease? Did they go back and look at when they had biochemical progression? Because that would be the true answer, if you see what I mean. So obviously Emma said the median is 6 months or whatever, but did they actually look on the individual basis what their historical results were?
No, because I think that in most of the cases that occurred at the same time, I think for the patients with clinical progression, from memory, unless Emma remembers differently.
Because in a way, that's the randomised study that needs to take place, is actually at the time of biochemical progression, making a randomised decision, option.
That is the problem with that study. So the patient numbers look impressive, it's over 1,300 patients, but it's retrospective and the decision's been made.
Yeah.
Like these patients have already been treated or not treated, so it doesn't move us any further forward.
Any other questions? Gui.
I think Charlotte deserves a word on her side, really.
Thanks.
So I used to think that we should wait, and I have been always very conservative about sitting on biochemical relapse, and partly because many patients are not keen to start treatment. Because when they start treatment, the clock starts ticking again for them, and then they worry about running out of options, and so I still am fairly conservative. I tend to sit on the patients, watch the tempo, perhaps repeat imaging, look at the urine light chains. But this man presented with renal failure. So he already has a vulnerability in his nephrons, okay? And the light chains are climbing, and I would probably err on the side of treating at biochemical relapse rather than waiting for CRAB criteria, if that is the only other point at which one would treat. But it's joint decision making with the patient. But in patients who present with renal failure and have light chain disease, I have a much lower threshold for proceeding with treatment on biochemical relapse.
Yeah, I agree. I think that was a particular argument in this case. It was also seen in that paper that often patients will relapse with the same end organ damage that they have at presentation. So you really are looking out for that, whether it's renal failure or bone damage or whatever. That's what you're trying to prevent. And I guess if they didn't have any of those at presentation, maybe you'd be a little more comfortable. But
Exactly. And if they do present again with renal failure, it might limit their treatment options and tolerability.
I'm going to ask Niels what your perspective is from a Dutch angle, as it were.
Well, the Dutch perspective, I think a little bit what Qui, I think, says. I look at how the patient presented, and if it's very aggressive presentation with a lot of trouble, I also tend to start earlier. And I carefully look at the kinetics. If something is going up like a rocket, I get very nervous and I start early. When it's and sometimes it goes very slowly, and then sometimes you can wait several years, in fact. Maybe now with the bispecifics, actually, I'm a bit more on the. I like to start earlier because tumor burden is really predicting your outcomes. So if you start with 100% tumor burden, teclistamab, elranatamab will only give 30% response. If you start a little bit earlier, biochemical progression, and your tumor burden is 20%, your chance is 70 to 80%. So I always say refer these patients for trials, for treatment early on, so that we optimize the chance that these patients get a CR and then 3 years of extra life.
And actually, how about the line of relapse? So would you treat it differently at first relapse versus second relapse, third relapse? In other words, would it influence your decision to treat earlier or later, in fact?
No, I think I always look at the presentations. And you also don't want to wait until a patient has deep cytopenia, like thrombopenia, because that's very troublesome. Because if a patient has thrombocytes in the end of 50 and you have to start KRD or DARA-KD, well, the patient has to
We can't do that in the UK.
The reason I say that, though, is that if you look at a case like this, classic post-auto case, either light chains or paraprotein reappears, and actually we've seen quite a lot just on our own practice on myeloma 11 who had to stop the lenalidomide because they reached biochemical progression, so they're no longer eligible to remain on study. Stop lenalidomide, and actually some of them just sat there for another 3 years. Whereas in even sort of third or fourth relapse, you kind of know what's happened before as well, not just what they've presented with, but you know how their relapses have behaved as well, and that's why I asked the question. It possibly influences a little bit, just from a personal experience of that individual.
But sometimes you can be totally mistaken. Maybe to comment on that, I have a patient who was 40 when he developed myeloma with spinal cord compression. He had to rehabilitate for many weeks, and in the end was able to walk and move everything as he did previously. So very aggressive, nasty presentation. So at the time of biochemical relapse, I wanted to start treatment. He was having some areas of PET positivity. His M protein was coming up, and I wanted to prevent again nasty stuff. But in a conversation with the patient, he didn't want to start yet. He wanted to carefully monitor, and I think we are already 5 years past by the moment that my fingers were itchy to start prescribing drugs up to a second transplant. And now 5 years later, he's coming every 2 or 3 months to my office, and his MGUS, like myeloma, has stabilized.
There's a question.
He didn't progress any further.
Sheila, question at the back.
Hi, thanks. Sheila McKinley from Myeloma UK. I just wanted to pick up on a couple of things that both Kui and Neil said, which is about patient view and actually how you approach this conversation with patients. What works, what doesn't work? Do you feel there are things you would like to know more about to better equip you to have those conversations?
Absolutely, thank you. Is there another question? No? Oh, Jam.
Sorry,
Jam. Yeah.
sorry, should we answer Sheila's question?
Yeah, it was a question. It wasn't a statement, it was a question.
Sorry.
Sorry, was it a question or a comment?
No, it was a question to say, how do you approach those conversations with patients, and are there things that you feel you lack, or are there things that could help you have better conversations?
So I think what Neil says is to try and understand what the patient might feel comfortable doing, and I think patients will sometimes express that quite clearly. It's very anxiety-inducing to live with the concept that you're relapsing without anybody doing anything about it for some patients. For others, the thought of going on to more intensive therapy compared to, say, single-agent lenalidomide is much more concerning, and I think that probably is all dependent on their previous experience of both their first diagnosis and potentially the toxicity of the first-line treatment they had. So knowing about those things and exploring those things with patients, I think, is important.
Can I follow on from that? So you mentioned the anxiety, the sword of Damocles that hangs over people if you monitor them. And would you tell this patient that I'm interested in what you both think. Would you use the word relapse with this patient, or would you not?
So I think in the case of this patient, and they weren't on the intervention arm of the trial, but if they had been, they'd have had to stop treatment. So you'd have had to have a conversation about relapse, and they will know that. You will be discussing with them their paraprotein. So yeah, within the context of the trial, they'd then be having an end-of-trial visit, and they would therefore know that information. Outside of a trial, I guess you would talk more generally about the changes in numbers and maybe not focus so much on the precise, what a precise number is or isn't in terms of INWD progression. I guess I'd have less of a discussion in that setting maybe, but they'd clearly be knowing that the paraprotein was changing, and that in itself induces anxiety.
Emma, what about you? Off the context, out of a clinical trial, would you use the word relapse with the patient or not?
I mean, our patients are often so well educated now. You know, the work of the charity groups and has ensured that. So many of them are really clued up, and you know, a lot of my patients will come with their notebook and want to write down their results. And you know, we may frame that conversation in the context of, you know, there are early signs that your myeloma is becoming active again, but at this moment. I was taking the Jam's name in vain, really, earlier when he was laughing at me being the person to defend waiting. And I think Niels's point is a good one. Sometimes it's about what do you think the next treatment is going to be as well, whether that's where that is going to be more effective. But because I work in the clinical trial space, sometimes I know I've got a slot on that a patient is now eligible for on a really good trial, and the standard care option is rubbish, and that might push me. But it's it is a very individual decision.
Great.
So just so quickly, I realize now that Sheila was waiting for a response, so a quick response, Sheila. Emma touched on a good point, which is that it's important to find out what level of information and understanding the patient has as to what the choices are, what the consequences are, and often patients have an idea of treatment only from what treatment they've had and what their experience has been about treatment. So I think it's important to explore what they understand about what's available and what the relative toxicities and the balance of risk-benefits are for them from the options that are available. And that takes time. Unfortunately, time is something we don't often have in clinics. So this might be a conversation you'd have to revisit again with patients. And this is where clinical nurse specialists, well-informed clinical nurse specialists, are really so important. But thank you for raising that, Sheila.
Jam, question?
Just sorry to come back to the point of the bone marrow. I think repeating genetics is really important in this case. I just wanted to make that point, because if you saw clonal evolution, you would treat. I would certainly treat. And the other point is, if you don't see clonal evolution, you have we've all seen these very, very standard risk relapses where patients biochemically progress very slowly. I say your disease is a bit more active, and everyone's seen it, 12 months, 18 months, even 2 years. And that's their only time off treatment, because then once they're on second-line treatment, they're on therapy till they die. So I think get as much information as you can, because there is a group that you don't need to jump into second-line treatment for.
Thank you. So we have overrun a little bit, but actually some really good discussions, so thank you. So I think we'll maybe just shorten coffee a little bit to ask you to come back at 25 to, if that's okay, for the final session, please. Thank you.
Crystal Wall's like was better than
Very
mine.
good. I mean, it's...